masanyu mukwano gwange nze nteeka mu kikapu njagale njawule ne mubalabe oli mulungi okuva wanomasamasa olinga kyakulya
London girls, come wine it for me. Come wine it for me. Canadian girls, come wine it for me. Oh, yeah. Come wine it for me. He said, London girls, come wine it for me. Oh, come wine it for me. Caribbean girls, come wine it, oh, wine it, oh. Many kind girls wine for me. Only you I see. I'm a cry, my fantasy. My Indomie, oh man, my love, 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 my love. You are the only one for me. You are the only one for me. My girl, you're the only one for me. You are the only one for me. London girls, come wine it for me. Come wine it for me. Canadian girls, come wine it for me. Oh, yeah. Come wine it for me. Say London girls, come wine it for me. Oh, come wine it for me. Caribbean girls, come wine it, oh, wine it, baby blow. Hey, love the way you wine that. Hey, love the way you wine that. Hey, love the way you wine that. What am I do? Same that is it. Love the way you wind that. Love the way you wind that. Love the way you wind that. Baby girl, you do me. Baby girl, you want me truly. Baby girl, you give me love. One that I never seen before. Baby girl, you do me. Baby girl, you do me truly. So baby girl, you give me more love that I never seen before. You are the only one for me.
Thank you. Ladies and gentlemen, we are about to begin in a few minutes' time. We'll have the anthems, beginning with the Uganda National Anthem, the East Africa's Anthem, and then the Lumasaba Anthem. Then thereafter, we will have the welcoming remarks by the Dean, who is Professor Julius Wandabwa, and then opening remarks from the National Democratic Institute. That will be represented by Roslyn Idele. After that, we will call on Dr. Benon Wanume to give us a preview of the bill. Thank you once again, ladies and gentlemen. My DJ, when you're ready, please, I'm ready. You signal to me when you're ready such that you're ready? Okay. Ladies and gentlemen, let's stand up and we do the anthems. Let's begin.
usimewele uwe shirifa akwongeleti habihunine nine feba masaba ube atwela nekwombe heshishalo shefe masaba usime mwambu ubuyani wanale babarera bikukabye bamasaba bikukabya sala inzu ya masaba usime lweliswani bulamu bwefe usime wele uwe shirifa akwongeleti kabihunina nine feba masaba ube atwela nekwombe heshishalo shefe masaba ulomba wele alinde umukuka amuweka makesini bulamu buleyi akuyete umone imbalu yefe wituze kwinyuhe bamasaba usimewele uwe shirifa akwongeleti habihunina nine feba masaba ube atwela nekwombe heshishalo shefe masaba.
Thank you very much. Let me now ask Mzende Konangaye to volunteer and give us a word of prayer.
Praise the Lord. Let each one pray silently for 3 minutes only. Thank you.
Thank you very much. Ladies and gentlemen, we can now take up our seats. Thank you very much. Before I proceed, allow me to ask those seated behind to come and occupy the front seats. Those seated behind, you can come through and occupy the front seats. Ladies and gentlemen, allow me to officially welcome you to Block 1, Annex Hall, Faculty of Health Sciences, here at Busitema University Mbale campus. Today, we are going to be talking about the proposed National Health Insurance Scheme, and the theme is towards achieving a universal health coverage. Ladies and gentlemen, with us we have a host, a number of notable guests. On my right here is Honorable Alicia Lasso, a former Member of Parliament of Serere. Now, Honorable Alicia Lasso is the immediate former woman Member of Parliament of Soroti. And during her tenure as MP, she served in various committees, including social sciences, social services, HIV/AIDS, education and health. She also chaired several committees in the Assembly, including the Select Committee on Internal Displacement in Northern Uganda, the Public Accounts Committee, and the East African Association of Public Accounts Committee. She is currently the Deputy National Coordinator for the Alliance for National Transformation Party and the former Secretary General of the Forum for Democratic Change. Honorable Alicia Lasso is here with us, ladies and gentlemen. On my left here is Dr. Benon Wanume, who is a lecturer and acting head of department, community and public health in the Faculty of Health Sciences, Mbale campus of Busitema University. Until recently, he has been the hospital director of Mbale Regional Hospital. In due course, he's just here. In due course, we'll be joined by Dr. Ian Clark, an Irish Ugandan physician, entrepreneur, and politician in Uganda. He is the owner and executive chairman of Clark Group Limited, which has interests in education, hospitality, and agribusiness. He has had extensive experience in establishing indigenous startup businesses and growing them to a corporate level. Ladies and gentlemen, those are some of the panelists that we are going to be sharing with very important and pertinent issues in regards to the proposed National Health Insurance Scheme. But before we get to them, allow me now take the opportunity to invite the Dean of the University, Professor Julius Wandabwa. You're highly welcome, sir.
Thank you very much, moderator and the coordinator of this. First of all, I want to make a correction. You know, the dean of the university is in charge of students. I am the dean of the Faculty of Health Sciences, and my name is Julius Wandabwa. I want to thank the National Democratic Institute and Busitema University for organizing this meeting. I want to thank Dr. Benon Wanume, who has been key representing us in our faculty in organizing this meeting. I want to recognize all the invited guests in your different capacities. There are many capacities here. Some of them I do not know. You are most welcome to Faculty of Health Sciences. But before we start the debate, I just want to tell you about the Faculty of Health Science at Busitema University. As a matter of introduction, Busitema University runs 6 campuses, and Mbale campus is one of the campuses of Busitema University, and Mbale campus is training medical students or doctors, is training nurses, degree nursing, is training a degree in anesthesia. We also have a master's program in public health. We also have a master's program in medicine, and also have a master's program in pediatrics and child health. So this debate about national insurance is key to us in the Faculty of Health Sciences, because we are training people who are going to offer these services. We are training people who actually need this national insurance to make their work a success. There are other campuses of education and science in Maragongera. There is another campus in Palisa, which is business studies. There's another campus for Busitema in Soroti, which is the Arapai for agriculture. And there is there's another campus, which is the headquarters of Busitema at Busitema, which is for engineering. There's another campus of environment and water engineering in Namasagali. So for those of you who have come here for the first time, this is just one of the campuses. Back to the topic which has brought us together here, I want to recognize the panelists who are here. I am sure they have a lot of information that they are going to give us. But one of our biggest challenge in health service is funding. You all know what the World Health Organization wants, what it has recommended. You all know what the Ministry of Health of Africa have recommended, and we know that the funding here has not reached that position. We also know the challenges that our people go through to fund health services or medical services. You need to have a sick patient or sick person for you to know how challenging it is to fund it. Some colleagues of mine have told me and have told us the experience that some health services in Uganda here are very expensive, especially as regards cancer. It's very expensive. Patients have complained that when they come, they don't get the services they deserve. We think that this national health scheme will address some of those issues. I know they won't address all the issues, but they will address some of these issues. And this national health scheme is new to us. We have read about it, but we want to hear about it. So ladies and gentlemen, you are most welcome to Faculty of Health Sciences, Mbale campus, this annex building. This is part of our home. And you are most welcome to listen to this panelist. I am sure you will hear their view, They need your view and they need your contribution to this national health insurance. This is what we are looking towards too. There are many insurances which are there in Uganda which are taking care of people who can afford. But this one should take care of everybody. With my friends, you are most welcome here. Let us hear what the panelists have for us. Thank you very much, the organizers and the funders, for bringing it here, and we shall be very grateful to listen to you and give our contributions. Thank you very much.
Thanks very much, Professor. A hand clap for Professor there. Thank you so much, ladies and gentlemen. Don't forget that this debate has been made possible by the National Democratic Institute in partnership with Uganda Radio Network. Allow me now call on Rosalind Idele to give her opening remarks. A hand clap for her as she comes through.
Thank you, John. Thank you very much, Professor, for the very warm welcome. Our distinguished panelists, honorable guests, ladies and gentlemen, thank you very much for honoring our invitation and accepting to be part of this important dialogue that we all need to engage in. I actually will not say a lot because Professor has actually made it perfectly clear why we need to be engaging in this discussion. So I will just tell you briefly about the program. NDI is partnering with Uganda Radio Network to create awareness about the proposed National Health Insurance Scheme. The reason we are doing this is because the bill was tabled in Parliament, and currently the Committee of Health is receiving feedback from members of the public. That means that we all have a chance to go through, see what is being offered, and give our feedback about whether or not that is the best way that we feel we should be able to receive this healthcare that we all so desperately require. The time has come. It needs to be done now, not tomorrow, not on any other day. NDI, in collaboration with Uganda Radio Network, will be recording these debates. We are streaming this live on Uganda Radio Network's Facebook page. We are going to share recordings of the debate with radio stations. We are also sponsoring talk shows on local language stations so that we can widen the discussion and make sure the information goes out there to as many people as possible. When we are done with the program, a report of this and the recordings of the debates are going to be shared with the Committee of Health so that it can inform the discussions and hopefully ensure that the model that we eventually end up with will be what works best for the people of Uganda. So thank you very much, and I wish you all the best in your deliberations. Thank you.
Another hand clap for Rosalind there. Thank you so much. Ladies and gentlemen, as you all may be in the know, objective number 20 of the National Objectives and Directive Principles of State Policy, as enshrined in the 1995 Constitution of the Republic of Uganda, states that the state shall take all practical measures to ensure the provisions of basic medical services to the population. While the United Nations Sustainable Goal number 3 is to ensure health lives and promote well-being for all at all ages. Article 16 of the Nations African Charter on Human Rights of 1981 is to the effect that every individual shall have the right to enjoy the best attainable state of physical and mental health, and state parties to present charter shall take the necessary measures to protect the health of their people and to ensure that they receive medical attention when they are sick. Ladies and gentlemen, other countries in Africa like Ghana, Kenya, they started on this some time back. Rwanda is doing so well. It's at about between 75 and 80%. Thailand is actually also in between there. They're also doing well. Tanzania is also on board. Ladies and gentlemen, we are now welcoming Uganda on board. And with me, like I earlier told you, is Dr. Benon Wanume, who is a lecturer and acting head of department, Community and Public Health in the Faculty of Health Sciences, Mbale campus of Sitema University. And until recently, he has been a hospital director of Mbale Regional Referral Hospital. He's going to be giving us a preview, and each of these panelists here is having between 5 to 7 minutes to do so. And after that, after they're done, we shall open the floor for discussion. You will have a minute of your contribution, and after that, we will be receiving your questions or opinions or contributions in sets of about five people, such that we allow the panelists to respond to them. Thank you, ladies and gentlemen. I now, with extreme joy and invaluable pleasure, invite Dr. Benon Wanume to give us a preview and his take on the proposed National Health Insurance Scheme. You're welcome, Doctor.
Thank you. Thank you very much, John Kay. I want to take this opportunity to thank the Dean of Faculty of Health Sciences for allowing me this opportunity to be part of this very important debate and also a very important topic of national health insurance. Before I proceed, Mr. John Kay, I want to welcome my big sister, Honorable Alice Alaso. We have interacted many times with Sister Alice, Honorable Alice Alaso, when she was in the August House and even in other fora, and she has been a very warm lady. I also want to appreciate the NDI for giving us this opportunity to be part of the discussions of the very important point of national health insurance. I want to sincerely welcome my chairman. I was, until recently, a member of this village, and when I see around, I see my chairman. Why don't you just wave to the members? Chairman LC1 Hospital Village. You are welcome, sir. I want to welcome members of Mbale Hospital. If there are any in this house, please, please raise your hands. Mbale Hospital for the last 8 years has been the best performing hospital in Uganda. We have 13 hospitals, referral hospitals, and all of them have been flexing muscles to displace us from that position, but they haven't made any headway. I want to urge all of my members in the hospital, please keep it up. Let's maintain our standards, and let's move until we get the end of it. Mr. John Kay, I have a small task of just bringing out highlights, first of all, of the universal health coverage, and then briefly, I will touch on the proposed national health insurance scheme. As you are aware, Uganda United Universal Health Coverage is said to exist when all the people in the country receive health care that they need without catastrophic expenditure after receiving this care. WHO also defines the UXC goals as to ensure that all people obtain the health care that they need without suffering financial hardships. Over 100 billion people worldwide still lack the basic health care. And it was along these lines that the UN General Assembly in 2012 called for all member states to pursue and tilt healthcare systems towards universal health care. UXC can only be achieved through publicly governed mandatory financing mechanisms like general taxations and social health insurances, and compel the wealthier and healthier members of society to subsidize on the poorer and sicker members of the society. Mr. John Kay, transition from UXC is highly a political process which will face great opposition, especially from powerful interest groups. This, therefore, calls for commitment from the highest level of political support. UXC is said to combine two elements. One, all people use the healthcare they need, and also the economic part, consequences that ensue after the use. People should be able to access the full range of the minimum healthcare package, and this must be all the time, which includes promotion, preventive, treatment, rehabilitative, and palliative care. Why should we move to PXC, to UXC? There are many benefits. One, there are health benefits as far as UXC is concerned. Those countries that have been involved or have embraced UXC have improved on their health indicators. Their child mortality has reduced, maternal mortality have reduced, and also premature death has also been removed. Economic benefits. Since the monies that were spent on health as out of pocket have reduced when you embrace UXC, many people in those countries which have embraced UXC have said to gain economically. Politically, the USA debate on Affordable Care Act, and this has been extremely controversial. We also know that Indonesia, new president, Mr. Joko Widodo, is called Joey, managed to get into this position when he implemented UXC. He was formerly the mayor of Jakarta, but on introduction of the UXC, it sprang him from the mayor of Jakarta to now a president of Indonesia. As you said, Mr. John K., the Constitution of Uganda empowers or mandates the government of Uganda to take care of all its citizens by giving them quality health care. We all know, don't we, that the finances to Ministry of Health has kept dwindling. We have some examples where people have gone into to seek services and they have left with catastrophic or devastating situations. As you said, Mr. JK, on 12th of August 2019, UTV featured a story of a worker who fell off a roof and was taken to a hospital and was with life-threatening injuries. This casualty, fortunately, was given emergency care and he improved. On discharge, this patient had over 20 million Ghana shillings of bill to pay, and this he couldn't afford. If it hadn't been for good Samaritans who supported him to clear this bill, we would have had bad news. This patient, however, was transferred to Mulago Hospital because he still could not afford to pay the bill for health care. We have another patient was detained in a hospital for failure to settle her bills. She went in for a delivery and she expected to have a normal delivery. It ended up into an emergency seizure, and on finishing the seizure, the husband could not pay the bill and he was detained in the hospital for some time until the bail was cleared. We have also known of a family whose husband failed to raise 400,000 shillings for a seizure. And the health workers at that time were demanding that this patient could not be treated until this money was paid. He had to rush and he sold a piece of his land and at a very high price to raise the money to save life of his wife. This couple, however, has lost the only source of income where they used to plant food and also other for sale, and are now living in perpetual poverty. Such stories are many. And I'm sure there are as many stories of this type as there are members of this community. Mr. Chairman, we know that the health financing budget stands at 7.5 trillion. Of this, the government of Uganda is only funding 15%. 41% is paid out of pocket, which is quite expensive and quite high. It is far beyond the 10% that is agreeable by WHO. And this shows that this is catastrophic expenditure. We have also known that the per capita of expenditure in the country is only $53. The recommended is 84. This is far below the recommended one. We therefore need to look elsewhere to finance health. And there are 4 possible ways that we can go for. The first one is the national health insurance, other insurance schemes, user fees, which was stopped because it prohibits the poor from seeking health services. We can also look at community health financing. Many countries, like you mentioned earlier, have embraced this and are making very good strides towards universal health care. Uganda has delayed up to now. You have said that Rwanda is between 75 to 80% of enrollment, which is very good. Kenya has started, and all people who earn more than 1,000 Kenya shillings receive or are supposed to take on the insurance. There are so many fears that are out there in the general public, and we anticipate challenges. One, we as the salary earners are already taxed because they are paying pay as you earn, they are paying local service taxes, they are paying many other taxes, and they fear that the national health insurance is going to overburden the already burdened salary earners. The current salaries are said to be insufficient to sustain households. There are also fears of possible mismanagement. Mr. John K., is this not going to be like the other funds that have been put together and has been swindled? There are also many other people who don't have regular payments, don't earn salaries, but they earn a good amount of money. The businessmen and other people who earn once in a while. How shall we catch these to improve on the pool of contributors? We have some possible benefits in this. Socially, there are going to be some social protection on catastrophic expenditures on healthcare seeking. We shall have increased access of the households to quality healthcare following competitive providers. We are going to increase our security on reducing tensions in households due to uncertainty in disease, when disease strikes. There will be increased productivity because a healthier community makes more economy. As I wind up, the proposed bill that was tabled on the 27th of June, 2019, to Cabinet seeks to ask government to allow them to levy a fee, a tax on all salaried, on all able Ugandans. It also provides that a person whose employment is salaried will contribute 4% of his salary. It also provides that the employer of such a person will contribute 1%. The proposed bill proposes that all other earners will contribute an annual fee of 100,000 shillings, and they shall benefit from what they call Uganda National Minimum Health Care Package. Furthermore, there will be some exemptions, and this will be the children under 18 years of age, or those who have gone beyond 18 but are still dependent on the parents, and also they very poor, and those who can't afford. Mr. Chairman, I want to end here by saying I think the best way to go to improve is to embrace UXC and also embrace national health insurance. Thank you very much.
A hand clap for Dr. Benon Wanume there. Thank you very much. In the meantime, I can see Dr. Ian Clark coming through. Thank you very much, Doctor, for making it here to Mbale. I'd like to thank you once again, ladies and gentlemen. Don't forget that this debate has been made possible by the National Democratic Institute and, of course, in partnership with the Uganda Radio Network. Thank you very much. We are looking at we are looking at the proposed national health insurance. And Dr. Ian, as you came through, we are having Dr. Benon Wanume giving us a preview of the bill. And we are getting over to to Honorable Alisa Lasso, the former Member of Parliament for Serere, woman Member of Parliament for Serere. Honorable Alisa Lasso, Dr. Ian, who has just come through, and other members who have just come through, is a former Member of Parliament for Serere, and during her term as an MP, she served in various committees, including social services, HIV/AIDS, education and health. She also chaired several committees in the Assembly, including the Select Committee on Internal Displacement in Northern Uganda, the Public Accounts Committee, and the East African Association of Public Accounts Committee. She is currently the Deputy National Coordinator of the Alliance for National Transformation Party and the former Secretary General of the Democratic Party. We also had earlier speakers of FDC. We also had earlier speakers. We did have the Dean of the Faculty, Professor Julius, and also opening remarks from Roslyn Idele from the National Democratic Institute. Welcome you, thank you. Ladies and gentlemen, allow me to take the opportunity to welcome Honorable Alisa Lasso. She was also the first Member of Parliament in Uganda to buy an ambulance for her constituents. Such a huge contribution. A hand clap for her. You're welcome, Honorable Alisa Lasso.
Thank you very much, John K., our moderator. It's indeed a privilege for me to be part of this discussion tonight and to thank the National Democratic Institute for the opportunity to be here. And also thank the university, Busitema University, for opening your doors to host us. It's a privilege to meet Dr. Wanume again and the entire team. As he said, we've worked together on a number of things. So tonight, we are talking national health insurance here. And I think maybe it's an overstatement, but I would say it's generally good to assume that it's a welcome development. It's something in the right direction that seems to be the way to go. My interest in this discussion tonight is the fact that laws and policies are not made just for the sake. There is often a situation to be cured. And my understanding, reading through the introduction of this bill on which the scheme will be premised, is that the proponents of the National Health Insurance Scheme seem to think that this bill or the scheme when in place has the capacity, I am assuming an inherent capacity, to cure all the diseases that have plagued the health sector in Uganda. And that has to do with the question of feasibility and implementation. And my thinking is that perhaps they are partly wrong when you think of it as the one that has, you know, the magic, the charm, that thing that can sort out this mess, then I would disagree with them. The thinking is that it should improve accessibility, affordability, and sustainability, and also the quality of our health care. And I think we need to really rethink that kind of understanding. Our health care, as Dr. Wanume already said, suffers from gross underfunding. So yes, medical insurance is the other way in which you can raise money to fund health service delivery. As he said, you can do it through taxes, you can do it through community mobilization, you can do it through public funding. That is one bit of it. And hopefully, when we go into the funding bits of it, we are able to look at who are we asking to fund. Currently, we are looking at ourselves as a country with more than perhaps 70% of people unemployed or underemployed or earning a wage, which is, recently Parliament threw out something about a minimum wage also. So the people we are calling employed could even be earning something like 100,000 shillings per month. And we are saying, if the way to fund this universal health insurance or national health insurance scheme is through taxing them the more, then we are talking about poorly salaried people being taxed the more. And if we pursue only that angle, we are not going to raise enough resources. But two, we are also going to attract resentment to the scheme. Secondly, we are looking at a scheme, the proposal in the bill seems to indicate largely the option of partnership with the private sector, and gradually that the government funding will be withdrawn and maybe concentrated more on specialized health service requirement. Now, I also have a problem with that kind of situation. If we address our minds to the private sector in Uganda, the private sector in Uganda, one, is largely informal. So how are you going to chase and get to account informal people to subscribe and to adhere to the requirements of the health funding scheme or the health fund, that they will be able to submit. You don't even know them, you don't know their addresses, they are not registered. And the private sector has always told us the attrition rate of new businesses in Uganda is over 90%. So they exist this year. Tomorrow morning, they are not there. That is the other question we need to ask ourselves. So without a properly constructed private sector, then we have a problem. The third bit of it is that our human resource, my assumption, I'm just assuming that the scheme is not going to entirely depend on the health, the private sector. So not on only private hospitals and private clinics, but government hospitals like Mbale Regional Referral Hospital, like Manafa Health Center, something, and so on and so forth. If we are going to address, as the bill presupposes, the question of affordability and availability, accessibility, if that is what is going to be addressed, then we need to look at the human resource component of our health sector. Where are they? And what is their level of motivation? This is a question we have engaged with over and over again. You do not expect poorly facilitated, ill-equipped, and paid nurses, doctors, to be fully available. They will have to find other sources of survival. So, if we want the National Insurance Health Scheme to work well, that means the motivation and the facilitation of our human resource in the health sector becomes a very, very key issue. The other thing that comes to my mind following the remarks of Dr. Wanume, he's told us the scheme has health insurance. It's taken off very well in Rwanda. The other areas is it's talked about is Kenya. And in the continent, you have Ghana and Botswana. Of course, each one of them relies on different models. The Rwanda model is largely the community-based funded model. The Kenya model is largely the hospital-based, is it national hospital-based model. The Ghana model, I think Ghana and Botswana are public-funded models. Public-funded models. Now, but I want to draw something from those four. Maybe I'll leave Kenya because there's something in Kenya that looks like Uganda. So I want to run away from Kenya for convenience. Rwanda, Botswana, and Ghana. Those three. One thing about them is the level of corruption in them is low. It's extremely important for us to think about that. And you know, now you understand why I ran away from our neighbors in Kenya, because they look like us sometimes on matters of corruption and fraud and mismanagement. But these three, because this scheme has to be administered in such a way that the dividends, people put in their little money. We are talking about farmers, we are talking about unemployed people, we are talking about people who work in the private sector and earn little, and we expect that they will make a contribution to this scheme over and above the taxes they pay on a daily basis to sustain the running of the affairs of government in this country. We do not want a national insurance fund which begins to leak, create leakages. And that is why the question of governance and the fight against corruption becomes critical in this discussion that we are having tonight. If we don't deal with fraud, mismanagement, the National Health Fund, which is supposed to fund the insurance, Health Insurance Scheme, can actually become a collecting agency which unfortunately will benefit a few individuals. And I think that is something we need to pay attention to. I also think, therefore, that the proposals in the bill, maybe Uganda might need to do something which is hybridish in nature. It might be helpful. But who exactly is the poor? The bill talks about excluding the poor, the vulnerable, I think children of below 18 years. Now, before I get to that exclusion, I just remembered something about preparedness, our own preparedness. This scheme will be moving us towards universal health care, which we all really want. Who doesn't want their grandmother, their relatives in every village to be able to go to any facility and get treated? I mean, all of us would be happy with that. Way back in 1997, or thereabout, we adopted another universal program in this country, and that was the universal primary education. At that time, the discussion was, are we going to declare all of it operational everywhere at all levels at the same time? And the politics came in and gave us a UPE where up to now we are grappling with issues of quality. So the children enter class, we know they can access, but they cannot read or write. So what is the level of preparedness in our country for the launch of this universal national health insurance scheme? Our facilities in a situation, in a state rather, where they can be able to offer such a service? Or should we begin to work towards that for some time, knowing that in 2022 or 25, that is what we will have, so that the basics are in place? Or are we going to use it now so that by the time the political animals like myself get into the field, we make it a campaign issue, say, now we want all of you to, something like that? I do not know. The last comment, as I said, is on these definitions of the poor. Who is poor in Uganda, and how many are they? And what is the position of government? Now I'm asking too many questions. For us, we are in eastern Uganda. Recently, National Bureau of Statistics released, I think, new surveys and said poverty had increased in eastern Uganda. So that means there will be more people to exempt in eastern Uganda, Karamoja, and a bit of the north, and something like that. I still believe that there must be more money in the consolidated fund put into our human resources, put into our health facilities to prepare them for a national health insurance scheme. Otherwise, it will be a name, but with a lot of challenges. Thank you.
Clap for Honorable Ali Salaso. Thank you very much, Honorable Salaso. Now, ladies and gentlemen, you can follow the debate on all social media handles of Uganda Radio Network, Twitter, Facebook, and Instagram. We have a very formidable team doing the work there from Uganda Radio Network. Those of you who have just joined us, that has been Honorable Ali Salaso, a former Member of Parliament, Serere District in Teso, and also she's currently the Deputy National Coordinator for the Alliance for National Transformation Party, one of the newest parties that we have, political parties that we have in the country. I would like to welcome all of you to this debate on the proposed National Health Insurance Scheme. And now we are getting over to Dr. Ian Clark, who is an Irish Ugandan physician, entrepreneur, politician in Uganda. He is the owner and executive chairman of Clark Group Limited, which has interests in education, hospitality, and agribusiness. A few months ago, I saw him tweet about his coffee brand, and that is very great. We also do coffee here. You're welcome. He has had extensive experience in establishing indigenous startup businesses and growing them to a corporate level. Dr. Ian Clark, you're highly welcome to Busitema University Faculty of Health Sciences, Mbale.
Good afternoon, everyone. And first of all, my apologies for being late. I went to the main campus of Busitema University. So I've traveled around the east this morning and this afternoon. It's a lovely country. Okay, well, you want me to make some remarks about the proposal? Yeah. So this proposal has been there on the agenda of the NRM for about the past 15 years. And in fact, there's been quite a bit of money spent with various commissioners in the Ministry of Health and so on, traveling to Israel, traveling around Africa, doing a lot of research over the last number of years. Most of those commissioners have now retired or been forcibly retired. And the team who is actually in the Ministry of Health now is a relatively young team with Ruth Gianna Cheng, Diana Tweeney, and the commissioners even are young as well. Forgotten their names of the Commissioner of Planning, the assistant commissioners. And I must say that the my feeling about I'm a private sector person, although I've been in the public sector in the sense that when I was mayor of McKindia Division, I was responsible for running a health centre for a KCCA health centre. And actually in McKindia Division now there's also Chirudu Hospital, which is quite a big, busy hospital out near Munyonyo. So I have experience, I should say about myself, where I really gained my understanding of the Ugandan health sector was in what we would say the faith-based sector, because I came into Uganda many, many years ago and set up a clinic which became Chiwoko Hospital. That was about between 25 and 30 years ago. And that hospital I'm still actively involved in. So that's what we call a faith-based or not-for-profit hospital. It has about 200 beds. It gives very cheap services because it's highly, highly supported by donors from Ireland and from Australia. So that's one, that's an experience I've had. And then I've had the experience of McKindia Division, and then I've had the experience of the private sector in setting up International Hospital, which is I think the leading or the largest private hospital in Uganda. And I also set up a private insurance organization called IAA Healthcare. And there's about 22 clinics called International Medical Centers. So I've had a long experience in the health sector, and I've seen the genesis of this bill go through from people who got a pool of money, did foreign trips, did research, held meetings, and really nothing happened. Until we're right now where we are in 2019, and the bill was taken to Cabinet. It went to the Ministry of Finance to get a certificate of whatever they get from the Ministry of Finance. Financial what? Okay, but that got a pass from there and so on. And then it went through Cabinet, and now it's come before Parliament. So this bill has been a long time in the making. My understanding, and I have to say this is like second hand, that someone told me that when it was passed through Cabinet, the President wasn't there, and that he's not a guy who's really keen on this particular bill, which is probably why it has sat there. The President doesn't put a high priority on health, as we know, because the budget really in health, we've had a decreasing budget for health and a massively increasing population. When I came here, there was 12 to, there was about, it was between, I can't remember if it was 12 million or 15 million people like that 3 decades ago. Now there's 41 million people. Now when you double your population, triple your population in such a short period of time, you can't expect the same resources or decreasing resources to actually then keep us all healthy. And so I say just impartially, I'm not in a political party like my honourable beside me here. I'll say impartially, I've been an independent politician, that we're not receiving the resources and health that are necessary. Now, on that basis, the Minister of Health and the people who are trying to now promote this bill, I felt that it's a means in which to bring more resources into the system. Actually, the Minister of Health has said that straight up to me. She said, it's a means in which we can bring more money into the system because we need more money in the health sector. And so therefore, the proposal in the bill is 4% contribution from the formally employed, plus 1% from the employer, and then 100,000 shillings from those in the informal sector and 0 from the indigent. Now, the numbers in the bill are really a compromise, because they had really wanted, and when they did the figures, it was 4% from the employee and 4% from the employer. But because the cost of doing business in Uganda is already high, so in other words, if you employ someone and you're paying them, they take home 1 million shillings. The cost to the employer is 1 million shillings, plus a further 5%. Sorry, plus the PAYE, which will be around 30%, plus a further 15% for national NSSF, plus your local service tax, okay, which is a small amount, plus now a further, it was going to be 8%, now they've reduced it to 5%. Now this is the problem. You're squeezing the pay packet. You're actually making it, the guy who takes home 1 million costs his employer like 2 million. And that is a problem. That's why the president doesn't particularly like this kind of thing. Because as you increase the cost of doing business in Uganda, you make it less attractive for investors. And so you're not able to attract the foreign direct investment, because the reason that they haven't passed through a minimum wage in Uganda is because, again, they want to make it an attractive destination. Say, here, you can get cheap labor in Uganda and you can employ our young people. Because don't forget, in that 41 million people, you have 70% who are below the age of 18, is it? 75% below the age of 35. And then there's a big percentage still below the age of 15. And don't forget as well, because this is a little demography for you, which is very important. Don't forget that we still have a rate of population growth of 3.2% per year, which is adding more than 1 million people to our population. So if you imagine the young people, we say we have a problem with unemployment, but behind that, as I drove along the road today, there was hundreds and hundreds of kids, school-age kids, and behind that again you have the toddlers, and behind that again you have the babies. So we're producing at a rate in Uganda that's really difficult for government resources to keep up with. And so then we say, well, we're trying to get to universal health care. In other words, to try and make health care available to everyone. So we're saying, how do we bring more money into the sector? So let's do national health insurance. So that they won't reduce the amount that's in the current government budget, but this would hope to bring a certain amount more into it. Okay, fair enough. And I don't, by the way, I'm as keen as anybody to see a good national health insurance scheme in place. But we do know that there's a lot of issues in it. And recently, I'm the chairman as well of the Uganda Healthcare Federation, which is the body that represents the private healthcare sector. So pharmaceutical companies, private hospitals, private clinics, equipment manufacturers, and so on. And we're all keen to see that we can get more resources into the health sector. We're keen to see that we would move forward in some sort of a increased insurance of the population. Why? Because when you don't have insurance, you have to find the money in your pocket. And when you get into a catastrophic medical situation, as it says in this leaflet is given out, someone can find themselves with a bill of 20 million shillings. Or find themselves suddenly, with these expenses. Whereas if you have more insurance coverage from national health insurance, from private health insurance, from community health insurance, then you're not caught out with these unexpected calls on your cash. So it's a good principle. It's a good principle that should be there, and no one disagrees with that principle. The question really is, as someone said to me earlier today in Uganda, we're good at planning. But are we good at implementation? Good at planning? Hopeless at implementation. Some of the plans that we have in this country that we did were just taken off the shelf by Rwanda. They implemented them and they went ahead. Because Rwanda is good at implementation, and that's why people hold Rwanda up as a good example of implementing national health insurance. Now, a couple of points I would make about the proposal here. The proposal that's outlined here is essentially setting up another insurance company. So we have, as I said, I set up a private insurance company. It's called IA Healthcare. It has about 65 or 70,000 members, which is a drop in the ocean. And there are other private health insurance companies. And so this proposal is basically set up on the basis of making the government run a big health insurance company. So essentially it sets up a collection, it says we will take 4% from you guys, 1% from you guys. We'll set up offices like the NSSF or the URA. We'll collect that money in, then we'll collect another 100,000 and we'll collect some money maybe from donors. And so that's what insurance companies do. They collect money and then they pay out claims. And that's essentially what we have here. It's then said for the people who'll give this service, we'll set up committees and they will accredit. In Bally Hospital. Does it meet the standards? We'll accredit it. Does it not meet the standards? They better, improve, right across the board. And then, when people come with their little card or their fingerprint identification or whatever that shows they're a member of the scheme, then you'll get this package of minimum, it's a long number of letters, but a minimum health benefits package, which will involve treatment of malaria, blah, 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 this sort of thing. So it's just like setting up a really big health insurance company. Has a director, has a board, and all that sort of stuff. Now let me tell you, what do they say the definition of madness is? Anybody tell me the definition of madness? Put up your hand. The definition of madness is repeating what you've been doing, hoping for a better outcome. And let me tell you, all of the private insurance companies are losing money. And yet they're charging, the least they're charging is 500,000 shillings per person per year. And the amount we're charging here is going to be 100,000 shillings. By the way, it's a good deal. 100,000 shillings for an informally employed person, for them and their family. Okay? So we're going to somehow, it's going to be like Jesus. Sorry, there's Muslims here as well. But you know the story where Jesus prayed for the 5 loaves and the 2 fishes, and they multiplied, and they fed the 5,000. Okay? So someone better start praying for the money that they bring in to the national health insurance from these contributions, that it multiplies and feeds the 5,000. Because it's 5 loaves and 2 fishes that are coming in. But we've got 5,000 to feed. We don't have 5,000, we have 41 million to feed. Okay? So, we're repeating, the private insurers, and I'm one of them, can tell the government, you set up a really big health insurance company, it is bound to fail. Maybe not today, and maybe not tomorrow, but it will fail. Because the sums don't add up. The amount of money you're bringing in, what you're paying out, doesn't work. Okay, but let me say this. And if I was here with the minister or with somebody I've been in meetings with the guys, the people who've written the bill. This bill is not badly intentioned. The people want to bring money in and improve health services. And actually today, as we speak, I think it's today, there's a conference in Manyonyo going on, sponsored by the minister and so on health prevention, health promotion, primary health care. Really to focus, to get people to focus on the very first bit, because I think it says there are 4 areas here, but one of them is it's listed in this little book here somewhere. But the first one, Cluster 1, Health Promotion, Disease Prevention, Community Health Initiatives. This is so important for us because If we can prevent an illness, it's much better than going to the clinic, and it's much, much cheaper. So if we can actually use some of this extra money to prevent people, to get people to do healthy practices in their lives, then we will keep them healthy. Professor Amaswa, who was the Director General of Health Services some years ago.
Dr. Ian, you have a minute to wind up.
Oh, yes, sure. Sorry, I don't know when I'm going on. Professor Amaswa said, health is made at home and fixed in the clinic. You don't take your healthiness to the clinic. You keep your healthiness by good practices, by what you do. Now, if we can actually improve the health of the nation, and that's what the Ministry of Health wants to do, probably as part of this money, then that's a good thing. But let me finish up with this by saying this. I do not see any reason, if we're going to do a national health insurance, why we do not use NSSF, which has already got all the offices set up, to collect the proportion that's to come. In fact, there's a lot of talk of NSSF themselves would do a health benefit for those people who are members of NSSF. It may not be a complete insurance, but a health, some degree. And I do not see any reason why we do not take advantage of that, because NSSF actually charges quite a lot here and has a very big pool of money and wants to attract more members. But that is not part of what's happened in the bill. As I say, the bill is more or less set up a really big insurance company. Thanks.
Thank you so much. That's Dr. Ian Clark. He came in a little late, but I think we are all at the same page now. We appreciate that he's given in a very wonderful contribution there. Ladies and gentlemen, the panelists, please feel free if you want to respond while standing. It is okay, because that's also part of exercise anyway. We are about to open the floor, but those of you who have just come through, we welcome you once again to Block 1 Annex Hall, Faculty of Health Sciences, here at Busitema University. The floor to take in a few questions. I don't know how Onesimus is to help out, to move around the microphone. It will be by a show of hand. If you have something to contribute or a question to bring forward, it's by a show of hand. Let's begin with the gentleman here. We are going to take in 5. Then the gentleman over there with the tie there, on a tie. We'll request you to first introduce yourself, and then you can ask your question. A minute, please.
Thank you, Mr. John K.
And comments as well, yes.
My name is Akim Watenyeri. I'm representing the Great Party, which liberated Uganda from colonialism, from marginalism, and we are again likely to come back and liberate again for the third time. Mr. John K., I'm already surprised and shocked to find Mr. Rand Smith or Rand Clark also lamenting about our health systems, because Rand Clark is among those. Ian Clark is among those who demonized the UPC government. He is among those who propagated.
I request that we don't get there. Let's stick to.
They are the people who spread propaganda all over the world, and that the government had failed to perform.
Watenyeri, thank you so much. Let me get to the next speaker. Ladies and gentlemen, I would like to request you to stick to the issues. The bill, to stick to the bill. Thank you so much. Before him, after him, we'll have the gentleman over there. It's okay, Mzee Konangaye. It's okay.
Thank you very much. Protocol observed. I'm the chairman, Keep American Task Force, Mbale Municipality, and the objective.
Can we have order, Mzee Konangaye? Can we please have order, ladies and gentlemen? Thank you.
I am the chairman, Keep American Task Force, and the objective actually is to be clean to mitigate diseases which are killing us every day. At my age, I'm 77 years and a half, because I've been able to look after myself very well. I'm a colonial generation, born in 1942. Therefore, this program is an issue. I have heard the speakers. I would like to point out that
Can we have order, ladies and gentlemen?
I have learned two things. The one side says we are not ready because there is no money. I seem also to understand that we need to find more people to put in the consolidated fund. Therefore, I would like to ask and to appeal that you leaders don't motivate people only for mass production. You seem to say government has a lot of money and you look after its citizens properly by paying high taxes, increasing teachers' salary, and so on and so on. But where is that money? Do we make it? Our GDP, that's total monetary value of what a country makes in terms of goods and services. Our GDP is only about $30 billion US. And our income per capita is only about 850.
Thank you so much, Mzee Konangaye.
Therefore, I would appeal that we encourage people to find methods of making money and adapt this scheme.
Thank you very much, Mzee Konangaye. Thank you very much. In the meantime, a new circular, we've got an increment of people's salaries. Don't know where that money will come from. Yes. Your name and...
Good evening, all of you. I'm called Okot Swipe. I'm a lecturer here. I will begin by saying, there is a saying that all soldiers wear green. All over the world, all soldiers wear what? Green.
Others wear desert brown.
What am I saying? The Uganda we are living in is related to the soldiers wearing green all over. The practice. This scheme, in its inception, has meaningful what? Purposes. But what is wanting as far as this scheme is concerned? Economy. Our economy is agro-based. And to develop this economy, you need to put a lot of money in what? Production. Unfortunately, our government has pumped more money in service sector, avoiding production what? Sector. That one alone erodes whatever developments you may have in place. Because they are not supported, they cannot be sustainable. You cannot run an economy on debts and handouts. What am I saying? You are opening districts every other day. You are opening cities, town councils, increasing the administration cost.
Wind up.
You have opened health centers. But what are these health centers doing? They're just buildings. What is there? Was it important to build them instead of strengthening those which were available? So what am I saying? I'm saying we need to go back to the drawing board.
Order, ladies and gentlemen. Let's have order as you wind up.
As we plan this insurance here, we need to go back to the drawing board. Begin with increasing money in production. If you move around,
thank you very much.
Mbale here, you need to account for our ATM. You need to account for our black. In Jinja, you need to account for our industries. Because those are the areas which you support the health sector.
Thank you very much.
Without even introducing what? The insurance scheme.
Thanks very much, Mr. Court. Let's get over to Dr. Bumba there. Dr. Bumba, the director of the blood bank here.
Thank you so much, John K. I'm Dr. Bumba Ahmed. I'm director of Mbale Regional Blood Bank. To start with, health insurance in whatever form is a good thing. However, the national health insurance as appears in this bill, in my opinion, is too big for us to chew and swallow as of now. Because we do not have the structures, but we also don't have the people's trust to give us their money. So not until we work on the structures, this is a very huge project. I want to agree with Dr. Ian Clark that we would borrow a model of NSSF where we have a smaller group of people start an insurance scheme, whether it is public servants and those in the private sector. From there, then we pick our lessons, build trust, and thereafter we can go en masse to everybody else. But in a situation whereby you don't know how many people are registered with private businesses, you don't know how many of those traders who work with produce, how much money they are making, then it's impossible for us to say that those in informal employment will make a contribution of 100,000, or some people who are absolutely poor will not make a contribution because we just do not know them. So we don't have the starting point for us to go this en masse. But we can start with the people in formal employment, then we learn our lessons, and over a period of time, then we can
wind up.
But health insurance is definitely a very good thing.
Thank you very much. That's Dr. Bumba. Gender balance. Where are the ladies?
Yeah.
Oh, she's here. Oh, Hajat, you're welcome.
Thank you very much. My name is Dr. Saidat Nachito from the Islamic University in Uganda, and I'm teaching law. My focus is on the bill.
Doctor, I would request that you stand at this point such that they can capture you. We are doing live streaming on all URN social media handles.
So my concern is on the bill, the payment. They're talking of 4% for the formal sector employees and then 100,000 for the informal. I think this is unfair because of the disparity in the arrangement. Because I may be earning 200,000 per month, yet a farmer is earning much more than I do. And it can easily be enforced. My employer is going to pay my money, or the remission, the 4%, even before I receive my salary, but not the informal sector. So I think there is unfairness and disparity in the law. And that will lead to less contribution because many people are going to dodge payment of the contribution, especially from the informal sector. And that means that we need to have perhaps an arrangement like Rwanda, whereby those who are paying more are entitled to more benefits. If I'm paying a huge sum of money in contribution, then definitely I should receive first-class treatment. I think that is fair, isn't it? Yeah, it is. I'm not saying that there shouldn't be a minimum package. Of course, for the poor people, there should be a minimum package. But first class, for those who are paying a lot of money, otherwise it's going to be unfair. It is working for Rwanda, it can work for Uganda. Then the other one is about implementation. Members are talking of, is it going to be progressive or full-blown? And I think the idea is that it should be progressive. Start with a small populace and then merge it as time goes by. So for this, because it is tagged to the right to health, the right to health is progressively realized or implemented. So I don't think we are in a hurry to ensure that everyone is on board. Let us do it piecemeal and then we can have good results. Thank you very much.
Thank you very much. A hand clap for Dr. there. Thank you. Another lady, before we wind up this set of the first 5 people that we talked to. Yes, there is a lady over here, please. I would request that possibly you come here such that we can capture you. We are doing live streaming. However, if you don't feel comfortable, you can feel free to make your contribution from where you are.
Thank you very much. I would rather, I'm painfully shy. Sorry, everybody. My name is Mercy, and I have had the chance to work with a couple of people in the health sector for the past 10 years. Now, my contribution is that, yes, I agree, we definitely need to move forward the the National Health Insurance Scheme side. But like Dr. Clark pointed out, that is the definition of madness. We seem to be rushing towards what's working for everybody else, but we've forgotten that we have bigger issues. Population growth, we're having an explosion very soon, as Dr. Clark has actually tried to give you the figures. So if you're thinking that we are actually going to have a couple of 25% of the non-dependents, that is because the rest clearly are going to be dependents. And then out of that, we have to take out those who are unemployed, yeah? Then we are looking at what, 10% taking care of 100%? So it might be quite hard for us to achieve. So I agree we should go towards that direction, but we don't want to end up like Nigeria or West Africa. I don't know which country it is that it completely failed after they lodged it and set it up.
Thank you. Thank you very much, ladies and gentlemen. We'll get back to the audience, but in the meantime, let's start with Dr. Ian Clark to react to some of the things that have been brought forward. Akim Watenyere was bringing in the UP standard demonizing. Please, let's stick to the real issues here. Thank you very much. Dr. Ian.
First of all, I'd like to point out that I'm Irish. I'm not British. Ireland is very different from the United Kingdom. So one of the issues that was brought up was we spend a lot in the health service at the present time. We spend on capital costs. So we put up new hospitals, new hostels, and so on, and we don't have enough in recurrent costs to actually run the system. And I think that's actually true. And another issue which was brought up was about trust. There isn't a lot of trust at the present time. And I must say that I'm trying to stick up for the people running the Ministry of Health at the moment, because I think it's the best bunch we've had for some time. They're not trying to steal the money. They're actually trying to do the best for the country. But of course, that has to be built up. And then another, the director of the blood bank, I think, made a very, very good point, which is let's do something smaller. Let's do something to introduce the trust, to bring more people into the insurance network. NSSF has built up trust now. It used to be a non-trusted organization, now it is. And let's start that and see how that goes. But it's a bit of a, and then there was another one about first and second class healthcare. The problem with that is that the money is supposed to come into a pool. The rich people are supposed to subsidize the poor people. And so I think what maybe in the thoughts on this bill would be that those who want the first class healthcare would top up and have a private insurance, and the private insurers would add on, so they would get some better health care from that. And then lastly, we had the mention of the really high dependency ratio in Uganda. It's just sums don't work if you have really a working population of 10% trying to give services for 100% of the population. It doesn't seem to work. So I think everybody's saying, yes, this is a good thing, but how do you proceed in a way that builds trust, in a way that brings money in? What I have picked up, I think, from the Ministry of Health and so on, they sort of hope to bring the money into the system and then improve the services and then introduce some payments so that there's a thing called results-based financing that's actually moving ahead at the minute. And results-based, do you have it in Mbale Hospital? Results-based financing. So basically, it's this, and I suppose they'll pilot it in some different places. But in Chiwoko Hospital, they're going to start, according to the district there, they're going to start, and it's a mission hospital, okay, and they'll do a delivery, a cesarean section for only 130,000 shillings. Now, 130,000 shillings in international hospital costs 1.5 million. Okay, so it's like a 10%. That's highly, highly subsidized. Now what the government is saying, well, look, if you're doing these highly subsidized operations, we'll chip in and we'll give you some money as well. Maybe give you like 90,000 or something. That's results-based. So if you're getting good results, we'll chip in. And if we see more of that coming forward through the Ministry of Health, we should see innovative ways in which we can make our money go further. Sorry for talking.
Thank you so much, Dr. Ian Clark there. Let's get over to Honorable Alisa Lasso.
Thank you. For me, it is maybe 3 comments. I do agree that, yes, it would be helpful if NSSF begins health insurance product for those that are within that category. I also want to encourage, if it were practical, government should leave people who are already under a private health insurance scheme. Let those ones also be maintained under the existing arrangements. And then the proposal then figures out how to get the presently uninsured completely and see how best to manage that. The second bit of my comments is the rich subsidizing the poor. That's really a good idea. But the rich in Uganda dodge taxes. They are the ones who are subsidized by the poor. I don't even know how they are going to get them. I mean, that is true. If you look for organizations that dodge payment of taxes to URA in this country, it's mainly the rich people. You dodge it in Mbale here, a license just expires, and you'll see the full wrath of Uganda Revenue Authority. But they dodge in billions, and so I don't know how they hope to get that done. And lastly, there is a concern about us wanting more money from the consolidated fund. And I keep thinking that as a country we have good money, even enough money to take care of our interests. The problem is this country has gotten its priorities wrong most often. You can end up with a hospital like Mbale Hospital having no medicines. But you can end up with the president donating 200 million to a presidential advisor on ghetto affairs just because, you know, really I think those are some of the areas where we get our priorities wrong. And we need money and the money is there, but
let's have order, ladies and gentlemen.
It's being misused. Some advisors never see the president for as long as they are alive.
Thank you so much. That's Honorable Isia. Let's a hand clap for her. Let's now get over to Dr. Benon Wanume.
Thank you very much, John K. I think I will have 3 or 4 reactions. One is from my chairman, keeping Mbale clean. I was working with you. I don't know what happened. Have I been sacked? Anyway, he says we're not ready because we don't have money. I think we need to make a start because I don't know whether we shall have a time when we think now we have enough money and we can now start the insurance. We need to begin with the small people who are available in the system and develop on that slowly as we enroll more people into the system. This is something with Mr. Swibe on the other side. He says we need to improve on the agroeconomy and on industries before we can start. Actually, it's true. If we are going to grow in this kind of system, we need to industrialize. And we need to bring in as many industries so we can get more employment. When people are employed, we can now enroll them in the insurance, and we can make more fund for that. I don't know how long that will take us. I don't want to venture into that one. Since Honorable Alice, you talked about the hybrid model. I think that's going to be the best way to go. We have the private model working together side by side with the public, and that's the way we must go. Thank you very much.
Thank you so much. Hand clap for Dr. Benon there, Benon Wanume. Ladies and gentlemen, we are taking on another set of questions, contributions, but be reminded that we are here at Block 1, Annex Hall, Faculty of Health Sciences, Sitema University, and you are looking at the proposed National Health Insurance Scheme. On the bench this afternoon, we have Dr. Ian Clark there, Honorable Alice Alaso, and also Dr. Benon Wanume. We also had apologies from Dr. Emmanuel Tugaineyo, who was unable to make it here. He sent in his apologies. Let's have this gentleman here. Then there is another gentleman over there. A lady somewhere. Anyway, let's get going.
Yeah, thank you very much for
your name.
My name is Dr. Joseph Matovu. I work with the Busitama University Faculty of Health Sciences. As I listen to the debate, I just want to throw a few questions to the panelists. They could probably help us to understand what is going on. So how many people are employed in the formal sector? Probably that would be important to know, because we are talking about 4% of people in the formal sector, and then the other people in the informal sector contribute 100,000, which means most of the money should come from people in the formal sector. So how many of them are employed in that sector? And that would be a very good beginning for us. The second question is, so who is going to collect this money? Who will manage the money? And who will account for the money? So those are questions that we probably need to have answered. Now, the last issue I want to talk about is the issue of poverty. I was looking at the poverty estimates for Uganda, and I realized that 60% of people in the Karamoja region are declared as poor. In Bukedi, it is 47.5%, Busoga 42%, Teso 40%. You know, you have 40 to 60% of the population is poor. And you say that the poor will not contribute. So who is going to contribute?
Wind up, Doctor.
Thank you very much.
Thank you so much. Hand clap for Doctor there. We have the gentleman over there, Wandulu there. The lady, then there is a lady at the back there. I've been told there is a lady at the back.
Thank you so much, John K. By name, I'm Roger Swandulu from Stronko. Greetings from Honorable Lydia Wanyoto. She's back. Please. My concern is, it's like guidance to Parliament before they think of National Health Insurance Scheme. Let them think of National Health Improvement Scheme. Things are not good. You can't insure what is not there. Okay? We need to be straightforward. This scheme is hitting a dead end. It can't succeed. If parents have even failed to contribute 10,000 for their children to take porridge at school, how is this scheme going to squeeze 100,000 from the poor people? Thank you so much.
Thank you so much, and thank you for being time conscious. There is someone at the back there. Someone at the back, then there is a gentleman here. Then we close set. Thank you so much. Welcome you once again to Busitama University.
Yes, good afternoon. My name is Julius Ntezi. I work with the Faculty of Health Sciences. I want to make my contribution to this debate. One is it hinges onto the relevance, the trust in the system. As the previous speaker said, we have a government that completely wants to ensure what does not exist. Let's look at Kawempe National Referral Hospital, constructed at a cost of 90 billions. By 2016, it is opened. By September 2016, it is leaking feces on the 4th floor and the ground floor. 2017, half of the time, the theaters on 4th floor are leaking feces, so they cannot operate. You have got, most of you have had your names and your contributions. You are all Ugandans, almost. We've had a system of numerous scandals from as a time we were youth to a time when some of us are becoming middle-aged. The time of the scandals in NSSF. Why am I bringing this? That we have no trust whatsoever of who is going to manage our meager resources that Museveni and his government intend to collect from the few people who are employed. If you make me, as a lecturer, who takes home about 3.5 million shillings, I'm saying that I should pay you 3 million shillings per year. What kind of services are you going to provide to me? When even the hospital where I work, in Regional Hospital, I cannot even access an X-ray service.
Thank you very much. Thank you very much, ladies and gentlemen. Don't forget that this debate has been made possible by the National Democratic Institute in partnership with the Uganda Radio Network.
I've been given the mic, so please allow me. to make my
But I'm the person in charge of this debate. But it's okay. It's okay.
All right. Okay, thank you. I'm called Emma Isaiah Erego. I'm a SHO, second year pediatrics, Busitama University. I just have 3 points to make. One, we are all moving around talking about everything. But the most important thing is that there is marked poverty in this country. So when you say that you give, say for example, the formal sector to contribute some money, say 4%, just like how Dr. Anteza said, it is almost inevitable. Economically, you will find it very difficult for me to give you the 4%, which I know I'm going to give another person to benefit. It is just economics, okay? And secondly, we have a very weak civil society. That is why when you try to make up a voice here and there, you find that the political aspects in the country tend to what? Tend to break you down. So we need more to improve on our what? On our civil society. And then thirdly, our priorities are wrong. And we need also to improve on our priorities. For the political people who are around, please make sure that is at least worked upon. And also we need to improve the infrastructure. Thank you very much.
Thank you so much. Ladies and gentlemen, we are done with the set of the 5. As we get back, we'll begin with that gentleman there because someone hijacked, but it's still okay since we are still within range. Let's now get over to the bench here. Beginning with Dr. Benon Wanume, reacting to the contributions, the questions of the members of the floor.
Thank you very much, John K. I want to begin with my colleague, Dr. Joseph Matovu. He was asking about the numbers of the formal and informal employment, who will collect the money, who will manage the money, and he was taking all of us seem to be poor, but because of 40 to 60% are poor. I think you're correct and you're very right. We need to make a start, because if we think we are poor and we can't begin, we shall remain in the same position. But if we make a step and begin slowly, and those few who can afford to put some money into the pool and keep growing as we improve, I think we'll make a big change. Mr. Rogers from Sironko said we need to improve health first before we put money in it. I think he's bringing a very controversial point of the chicken and the egg. Which comes first? Do we first have the chicken, or do we first improve before we can add money, or give money and improve the system? I think this is a bit of a challenge, and it can be a bit very tricky. Marked poverty still is yes. Civil society is weak, yes. And we need to actually improve on the civil registration, because here then we could know how many people are in the informal sector or informal employment, and then we could catch this, their contributions into the pool, and then that could help in managing the fund. Thank you, sir.
Thank you very much, Dr. Benon. Let's get over to Honorable Lisa Lasso.
Thank you. I just want to say that the bill provides for, because the question was asked who will collect the money. So the bill provides for a collection agency, which is called, I think, an insurance scheme fund, something like that. Ensure that the money is transferred. And then it provides for penalties so that those who do not fulfill their obligations can face arrest, can face, I think I read somewhere where you might have to double the contribution if you don't make it in time. Instead of maybe 100,000, then they might take 200,000 as a penalty from the defaulting person. So that's provided for there. But I want to address the issue of trust in government in relation to this bill. it means that this scheme, the management of this scheme when it is put in place, will then have the responsibility to sort out claims. So we go for treatment, maybe Dr. Ian Clark will handle this better. But we go for treatment, then we are treated, and then they will submit claims. And if you are dealing with a system where there is a country where there is systemic corruption and fraud, then I can imagine them having, blotting the claims, and before we know, that fund will run short of money because people will be,